Hi, I'm Cyan Gibbs, and I'll be presenting the physician's orders pertaining to the patient who has acute respiratory distress syndrome. First, I will order the ABGs, and the results show that he had a PaCO2 of 52 with a pH of 7.2 and a HCO3 of 24. Now, with those labs, it shows that this patient is in respiratory acidosis. He also is hypercapnic. Blood sugar was checked and it was 89, so no issues there. The patient's current SpO2 reading is 83% on 2 liters, which is not really good. We're going to try to bring that up. So also the patient will probably be admitted to the ICU until they're stable enough to go to the progressive care unit. So with that, we'll start with non-invasive ventilation. So usually this is used for hypercapnic respiratory failure patients. It's not invasive. It's not like the patient's being intubated. This involves just a mask around the oral cavity to support patient ventilations, basically. It will also be initiated first because of the positive outcomes associated with versus mechanical ventilation. Some of those risks with mechanical ventilation include infection, but with non-invasive ventilation, it decreases the risk of infection and also increases the patient cooperation with physiotherapy. So with breaking up any kind of mucus or any kind of deep breathing, the patient is able to basically participate because they're not intubated. They're able to communicate effectively. They're able to tell us they have pain, or it's just a lot of positive outcomes when it comes to non-invasive. So that'll be the first thing that I will initiate for this patient, so they have the ability to cough and also to receive nebulizer treatments by respiratory therapists. For this patient, I'll also just keep a close eye on him. We would adjust the supplemental oxygen to get a goal of oxygen saturation of 88 to 92% while on the non-invasive ventilation. I'll also order some Q2 neuro checks just to see how the patient's mental status is. Usually when they're in acute respiratory distress syndrome, they're not all the way there. They kind of have an altered mental status. So I guess by doing those Q2, Q1 neuro checks with a success there, sometimes it can tell us if their oxygen saturation is getting better just by them coming to and being able to be alert and oriented. I will also have the patient on Q1 hour vitals. The patient was already admitted with a low blood pressure and a low O2 saturation, so this continuous monitoring of that will be necessary. I will also withdraw the ABGs after we start the non-invasive ventilation in order to see if there's any kind of improvement or if there's an increase in the PaCO2, whether or not it's within normal range or is it starting to compensate. I would definitely do that. I will also initiate a 500 cc bolus because the patient was in the 90s or 40s to get it up. Then we'll recheck that blood pressure. And then once the blood pressure is at a goal of maybe 90s over 50s, 60s, and we'll start to have continuous infusion with normal saline 125 ml every hour after the bolus is finished. That concludes my part of the assessment and the physician's orders. Thank you.